Well, good afternoon, evening, morning. Welcome, everyone. It's Tracy Jarvis from PESI UK, and we are going to be talking trauma-related dissociation. And I have a really special guest on our clinical spotlight, Dr. Ruth Lanius, researcher, clinician, and an incredible psychiatrist. So a warm welcome to you, Ruth.
Thank you so much, Tracy, and thanks for having me. And I look forward to our conversation today.
Lovely. And I forgot to say, if you're new to our clinical spotlight on a Thursday, please do let us know that you're new, and a very warm welcome to you too. So Ruth, let's get down to basics. Talk a little bit about what is trauma-related dissociation.
I think going back to Frank Putnam's work, it can be very easy to describe. It's essentially a psychological escape when no physical escape is possible. So it's really the mind, brain, and body adapting to something they can't escape. And I think when we're talking about dissociation, it can mean a lot of things. So we have to get a bit more specific and realize, as we all know, dissociation can refer to, for example, reliving flashbacks, right? One of the soldiers hearing a helicopter and then taking cover, losing connection with the present and actually feeling like he or she may be back in Afghanistan. So that's one form of dissociation. Then another form of dissociation, of course, is also out-of-body experiences. And here people sometimes disconnect completely from their body, looking at their body from above, or they can feel like, for example, their hands and their feet are disconnected. And I think what's so important to realize is that dissociation at the time of the trauma is incredibly adaptive, right? It helps the individual to survive. So there's a reason individuals dissociate, and it really works to increase survival. For example, I have a patient who was gang raped repeatedly during her adolescence, and she describes beautifully how she disconnected from her own body, how she felt she was up in the tree looking down at her body, which was being assaulted. And she describes, I couldn't feel it. It wasn't me. I was disconnected from that body. And she even goes on to say how she could have empathy for the person who was down being assaulted. So we can see the adaptive response, right? But of course, in the aftermath of trauma, when we're disconnected from our bodies, and that's so common, of course, after trauma, right? That we don't feel. We're disconnected from our bodies, which is really the seat of our feelings and our emotions. And so then we can't feel positive and we can't feel negative emotions. And we feel emotionally dead. So in the aftermath of trauma, it becomes really difficult. And I think that's why we work so hard with people to slowly reconnect them with the physical sensations in their bodies. So that's another example of dissociation. Then we have derealization, right? Feeling like everything around us is unreal. And again, at the time of the trauma, that's protective, right? It's not really happening. This is not real. And the extreme would be, I don't exist. Things are so unreal that I don't exist. Again, when you're going through something that's intolerable, that's a blessing. But then in the aftermath of trauma, if nothing feels real, that becomes really difficult.
Yeah.
Right? And then moving into the more complex spectrum, where individuals start feeling that they have a very fragmented sense of self. And they have periods where they can't remember what they did, what they bought, or what emotions they've had, where they lose chunks of time. And again, I think that comes down to difficulties with emotion regulation and having to separate from memories and emotions that are intolerable. Right? And so when you're carrying so much shame, so much sadness, so much anger, you can't experience that all in one state of consciousness and have access to it all the time. It becomes intolerable, right? Mm-hmm. And so again, the self starts to fragment, I think, in a brilliant way. right? So it feels like actually that shame, that doesn't belong to me. That's somebody else's. Or that anger, that's not me. That's somebody else's, right? And I think that's how individuals continue to cope in day-to-day life, right? Dissociating those intense emotions and memories.
Yeah.
And again, during the trauma, it's a blessing, right? And even in the aftermath, it can be very adaptive, but you don't feel whole, right? You lose that, you never have a sense of wholeness, or you lose that sense of wholeness. And, your memory is like Swiss cheese, right? You have holes in it. You can't follow your life. You don't have a continuous sense of self in context with the past and with the future. And so you also don't have a proper sense of time. And so in the aftermath of trauma, that becomes really difficult, as we know. And that's why we work towards that wholeness, the wholeness really of brain, mind, and body. And not just alone, but also having that wholeness and being able to be in a relationship and sharing that wholeness with another.
Ruth, I just love how you have really, said that, basically dissociation is really adaptive as a form of survival and coping. I think that's such a, that's one of the biggest messages that we can give. It is certainly that it's just a normal response to an unbearable situation.
Exactly. And I think so many people feel they're crazy, right? They're hearing voices. The voices are arguing, they represent different parts of themselves. They don't feel unreal. They're out of their bodies, right? And people think, oh, I'm going crazy. But I think it's so important to realize, no, you're not going crazy. Your brain, mind, and body did an amazing job. And now we just have to bring all this to the present and help you adapt to the present.
Yeah, yeah. Ruth, talk a little bit about, and you so eloquently described dissociation. Talk a little bit about, why do you think the brain does that? Like, is there too much, why does, and you might not know the answer, but when you said that, I was like, oh, before I ask about sort of what sort of brain structures are involved, like, why does the brain, do that? Or don't we know yet?
Well, I think we've been thinking a lot about this as a group, and of course, not just a group in London, Ontario, but as an international group. And I've had a lot of discussions with Seaborn Fisher around this as well. And I think it's so important to realize for the longest time, we've described the brain as being abnormal in trauma. And I think that is really an incorrect way of looking at it. I think the brain adapts. I think the brain and body are brilliant. They adapt to the trauma. And that's why we see different brain activation patterns and different networks coming online. And I think it's really to cope with the trauma. And so if somebody undergoes developmental trauma, during a time when the brain is most malleable, right? The brain rewires, the brain adapts to the impossible or to the unbearable, as you just said, Tracy. And it helps the individual to survive. And so when we start working with somebody, I think we really need to understand that this is a brain that's adapted to horrific experience. And how can we help that brain, mind, and body to come to the present now? Hopefully the present is much safer now. And the person can come back to their body, befriend their internal sensations. And how can we help the brain do that? And often people say, I want to train the brain to be normal, whatever that means. But, when the brain has adapted like this, taking the brain to what we would call a normal brain to somebody who's never had trauma, I don't think that makes sense, right? So this is a brain that's been brilliant. And now we need to help that brain come to the present. However, that brain needs to do that. And I think it needs to be very personalized because, people have had different experiences. brains have had to adapt in different ways for each individual. So to really work with each brain, mind, and body individually to help it come to the present and realize its strengths.
Yeah. Yeah.
And its capacity to adapt. And we, of course, know that the brain is malleable, right?
Mm.
Way into adulthood. We know that it's plastic. We know that we can have this neuroplasticity. And I think we see that as clinicians, right? And that's what keeps us motivated. And that's what keeps us working with individuals, right? Because we know that they can change. And by changing the brain, we're changing the mind and we're changing the body. And we're changing the self in relationship to the other, right? We're creating, the capacity for an individual to be with another, to be safe with another, and to develop trust.
And I don't want to venture off too much because I kind of want to go a little bit into the brain, but you said something really important, which I also just loved, which was, some of the most brilliant people I know, actually some of the most brilliant people most people know, have had trauma. And those kind of like genius elements really are a gift from an adapted brain.
Absolutely.
And so why lose that, right? When the brain can be adaptive, right? And then they can have both at the same time. They can still have all of that genius, that adapted brain.
Absolutely.
Yeah.
When I think about some of my patients, I mean, the creativity, the brilliance, the eloquence, right? It's amazing, right? And really honor that and help them to see that, right? Very often they would say, what? I have strengths? You're crazy, right? But to really help them to see that and, honor their brain, we know that it's caused a lot of pain for them at the same time, right?
Yeah.
But to honor that, as sort of a beginning of treatment and then slowly start realizing all those strengths and bringing them into the present, right?
So Ruth, I asked you about sort of why does the brain dissociate? My next little question was going to be, research has come on, just tremendously since sort of fMRI, neurofeedback, different sort of neuroscience techniques over the last, 30, 40 years. We used to think it was pretty much about the amygdala. Talk a little bit more around other brain areas that people who are interested in trauma really need to know about.
Absolutely. And what I'd love to bring in here, Tracy, is, we certainly need to know about certain brain areas, but actually that's not how the brain works, right? The brain doesn't work as one area activating. That's not how the brain works. The brain is so connected, right? All parts of the brain are connected. So if we change one part of the brain through its connections, we change many different parts of the brain. And so the brain really functions as different networks. So different parts of the brain firing together at different times. So for example, when we're, off task, when we're just relaxing, a certain network comes online, as opposed to another network when we're actively engaging in thinking and planning, right? So different parts of the brain start firing together depending on the need of the individual. And so I think it's so important to think about the brain as different areas of it firing together. But coming back to your question, what do we need to think about when we think about dissociation? I think one area that has been very much studied is called the temporoparietal junction. It's sort of an area right here. And we know when we stimulate that, for example, people have out-of-body responses. And, we see that repeatedly. Simone Reinder's group has shown that in dissociative identity disorder. We've shown it repeatedly in post-traumatic stress. It's been shown in neurological conditions that have out-of-body responses, for example, migraines. But what's really neat, I think, is, and what we really have to incorporate more into our understanding of the brain is we need to go deeper. Brain imaging to date hasn't been good at studying the very deep parts of the brain, the brainstem and the midbrain. And those parts of the brain are really critical for trauma because they are all about innate and reflexive responding. And so, for example, say somebody comes into my room here and assaults me. Like, I've got to react in a split second, right? I can't engage my higher brain, my cortex, and reflect, oh, you know, I wonder if this guy is going to kill me. That's not going to work, right? That's not going to increase my survival, right? So what I need to be able to do is I need to perceive the sensory input at a subconscious level and then run and get the hell out if there's danger.
Yeah.
And this is what this deep part of the brain, the reptilian brain, does. So it picks up sensory cues from the outside and from the body, and that it can actually engage movement and action, defensive responses from bottom up without even being aware, consciously aware of them. And so I think really gaining an understanding of that part of the brain, and a key brain region in that part of the brain is called the periaqueductal gray. Jaak Panksepp has done a lot of work on that, I think will be critical. And what we're actually seeing is that this part of the reptilian brain has direct connection to this part of the brain that's involved in out-of-body responses.
Interesting.
So it may drive those out-of-body responses when you get a sensory input that is really overwhelming. And if you're used to responding through out-of-body responses, if you've had a lot of chronic inescapable stress where out-of-body responses served you really well, that part of the brain may very quickly drive those out-of-body responses. And so I think really incorporating that part of the brain into our understanding of all of the rest of the brain will be critical. And of course, it's going to have profound effects on the rest of the brain: emotion, thinking, planning, agency, connection, because it's connected to all the brains, the rest of the brain parts, right? And so changing the brain down here is going to change emotion, it's going to change thinking, planning, agency, and connection.
Poor cognitive psychology in the next 30 years.
Well, I wouldn't say poor cognitive psychology, but I think cognitive psychology needs to embrace that part of the brain and needs to embrace emotion, right? And how emotion has such a profound impact on everything we do.
Yeah, sure. Right? I'm just being a bit naughty.
No, I completely understand where you're coming from.
So just coming back to what you were saying, what I think you're saying is that for us to understand as clinicians that it's more about brain networks seem to go often online or don't sort of function as well as they could, when traumas happen. And really through the therapeutic work, what we wanting to do is hopefully get those, like a good MOT or you don't have MOTs, but a good car service, is get everything kind of working in the right way so the engine kind of, works together like a full engine.
Absolutely. Yeah. To adapt these networks back to a situation of safety of the present and really help the individual function in the present.
So I want you to talk a little bit about, I was reading a couple of papers that you had been involved in, and I want you to talk a little bit about sort of trauma-related states of consciousness, really just the basics. What are they? Why do therapists need to know about them? How does it affect clinical practice? Just some really kind of headline figures, because we don't have a huge amount of time, and I kind of wish we had the whole day, but we don't. So yeah.
Yeah, absolutely, Tracy. And this is something my colleague Paul Fruin and I have thought a lot about, and we actually wrote a book for it for the Norden Interpersonal Neurobiology series. And so there was a paper years ago by Sahabi and Thompson out of Toronto looking at 5 different dimensions of consciousness. And these dimensions were time, thought, body, emotion, and intersubjectivity. And we'll talk about it in a second, what they mean and how it may be important for trauma. And as Paul Fruin and I were reading about this, we thought, my God, this is so relevant for trauma, especially for dissociative symptoms. Mm. And so we started thinking about these 5 dimensions of trauma in terms of having both a non-dissociative and a dissociative dimension. And we really saw an overlap with altered states of consciousness and the dissociative dimension of each of these dimensions of consciousness. So if we look at them really briefly, for example, the dimension of time, right? So time is really being aware of the now, and normally time is always forward moving. And when we think about how this may be relevant for trauma, of course, we realize that our traumatized clients have such difficulty being in the now, right? And they spend so much time reliving the past or worrying about the future, but that being in the now is very, very difficult. And I think trauma is also the only condition where time is not constantly moving forward, right? That, when you're traumatized, there's a loss of sense of time and people go back into the past, right? Mm. Which I think is really unique to trauma. So understanding how sense of time gets interrupted in trauma, I think is critical. And again, we're aware of certain parts of the brain that really help us to have a sense of time. And those parts of the brain go offline in trauma. Hmm. And one of them is the prefrontal cortex, the dorsolateral prefrontal cortex, which is critical in having a sense of time. And so how can we bring those parts of the brain online in the aftermath of trauma to reestablish a sense of time, right? Again, to be able to be in the now and not go back in time, to have time continuously moving forward, I think is critical. Hmm. And again, when we think about how is this adaptive losing your sense of time, when we think about, when we have car accidents, very often time slows down.
Yeah.
Right? And people will tell us, oh, I was so glad time slowed down because that gave me the opportunity to figure out, what actually to do and how to end this accident in a safe manner at times. Right. So again, it's adaptive during the trauma often, but then in the aftermath, it becomes maladaptive. Mm. And so that's the dimension of time. The dimension of thought really deals with telling a story, there being a narrator, there being a beginning, middle, and end. And when we think about telling a story, it's usually told in the first person perspective. But as we know, when we have individuals that have altered states of consciousness and dissociation, often they lose that first person perspective and they now have voices commenting. And so now their narrative becomes chained, it becomes shared among 2 or more different orators with very different, affects, different perspectives, different emphasis. And so I think that can really be a reason for having these trauma-related voices that are very common and lead to this inner conflict, right? If we have different voices with different affects, different senses of time, different emphasis, right? Different points of view, that can lead to tremendous conflict inside. And people will often talk about how they feel torn apart in their head because, and it's so loud because of these different voices. And of course, it's reflected in the body, by inner tension created by this inner conflict.
Can I just ask on that point? Yeah. There, I don't know if you've done any fMRIs on that. Do you sort of see with that kind of, different conflicting states with affect, etc., time, do you see different areas of the brain sort of lighting up, or are they on the same networks?
That's a great question. And we're just looking at the different dimensions now. We haven't analyzed the data, but there is some work done by Simone Winders, actually in London, in the UK, as well as Schlumpf, that have looked at 2 different states. So one state that is sort of amnestic to the memories, doesn't have access to the memories, and functions in daily life. And another state that is really bothered by traumatic memory recall and gets really hyper-aroused at times. And yeah, very different networks come on in the two different states.
How interesting.
Yeah.
Yeah. Sorry, I completely interrupted your flow
No,
there.
not at all.
I just with my inner geek, I had an inner geek voice that said, you got to ask that question.
No, it's very important. So thanks for asking it. And then there's the dimension of body, right? Incredibly important. And of course, out of body responses would be reflective of altered states of consciousness. And we've talked earlier about how important they are, again, how adaptive they are in the midst of trauma and how maladaptive they can be in the aftermath of trauma. So that would be dimension of the body. And then dimension of emotion, we hypothesized altered states of consciousness to really deal with severe emotional numbing where you feel completely emotionally dead, or when you have the compartmentalized emotion, right? Where you feel like the shame or the anger, that doesn't belong to me. That's experienced by a perceived other, which you would have in dissociative identity disorder, for example. And then the last dimension dealing with intersubjectivity, and that being with another would really involve sharing their dimensions of time, thought, body, and emotion. That those, in order to be with another and to mentalize and be, aware of somebody else's feelings and emotions, would be sharing those 4 dimensions of consciousness between 2 or more people. And something I also learned from my patients is that, without a sense of self, which you often don't experience if those 4 dimensions of consciousness aren't online. So without a sense of self and without the integrated experience of time, thought, body, and emotion, there also is no other. And the other only comes online once those 4 dimensions of consciousness become integrated and once an individual develops the experience of a sense of self.
But there is a self, but it's not present.
Yes, it's not fully developed.
It's not fully developed.
Absolutely. Yes.
Yeah.
I think that's really important to point out. Absolutely. Yeah.
Because I think, sometimes probably with your patients, where people say something like, well, it's happened to me. I'm never, ever gonna, have a sense of self or this or that. And it's actually, no, you are. And it is there. So we're on the same page that there is a self, but the networks are basically offline.
Exactly. And it's almost like, moving from larva to butterfly, right? I often use that analogy, right?
Beautiful.
Yeah. Right? We're really working towards allowing the butterfly to emerge.
Very rich.
Yeah, and I often say, don't mess with the larva. Just, it'll come, right? Don't do too much. And I think acceptance is a huge part of that, right? Yes, things can be incredibly painful, but we're working on different methods to process material and to help you to come to the present and realize your strengths. But yeah, it's going to come. It's just going to take time.
Ruth, for clients who dissociate, in your view, what is some of the most helpful information for therapists to know right now? Because you're really at the forefront of the latest research, probably with the hospital, doing amazing work at the forefront of trauma treatment. What do you think sort of right now is really helpful for therapists to know who work with dissociative clients?
And again, dissociation can refer to so many things, but let's just start with the very basics, right? So when an individual dissociates, they aren't able to be here in the present, right? So they're zoned out, they're not present in the environment, and often they're very disconnected from their own bodies. So how can we reconnect them to the environment, right? So using the five senses. You know, what do you see? What do you hear? What do you feel? Can you feel the feet on the ground? Can you feel your butt on the chair? Can you feel your hands on the table? Do you need a strong taste to bring yourself back to the present? For example, a strong mint, or does a certain smell help you to come to the present? Or, for example, does looking at a picture of your child help you to come to the present? So again, individualizing the approach, right?
Yeah.
And creating a grounding kit for each individual client. So that's coming to the present, being present with the environment. But then, of course, we also have to help the individual to start being present with their own body and slowly start to befriend their inner sensations. And that's terrifying, right? Because as we know, the body keeps the score, right? And so, reconnecting with the body, again, needs to be done, I think, in a very personalized fashion and at a rate that feels safe and comfortable for the client. So again, it's having the client in the driver's seat and checking in with them and getting their regular feedback about what it's like for them to start to slowly become aware of what physical sensations they experience in their bodies, and really titrating it so they stay within the window of tolerance. And so we go very slowly and, over time, and this may take weeks, this may take months. I've seen traumatized individuals slowly become aware of physical sensations in their entire body. And then, we do body mapping, right? We figure out, what specific physical feelings in the body are connected with what specific feelings and emotions, because that's what we have to get in touch with. Because individuals who are disconnected from their body, as we talked about, can't feel positive or negative feelings. Doing that body mapping and really helping individuals to feel again, I think is
important. So even just feeling like, I'm just thinking about, everyone, 1,500 people that signed up today, but even just getting clients to notice a sensation that's totally neutral.
Absolutely.
Like, for example, I don't know, my thumb, if I feel my thumb right now, it's pleasant sensation. So rather maybe starting off on the, not even pleasant, actually, that could be sort of a trigger, but just on neutral. So just, yeah.
Yeah, and what you say, Tracy, really brings up a woman I was working with years ago, and she was completely disconnected from her body, and she couldn't get in touch with any physical sensations for the longest time. And so what we worked on is that I got her to exert pressure on her forearm, and that's the only thing she could feel for months. And so she kept exerting pressure, and then first on her arm and then on different parts of her body. And that was the first sensation she became aware of. And so if somebody is unable to become aware of any physical sensation, I think that's a really helpful tip, right? Just to exert some pressure and see whether they can feel any of that.
Yeah.
Yeah.
So five senses, getting in touch with the body very slowly. Anything else, Ruth?
Yeah, so for example, if we then move to disembodiment or depersonalization, which is so related, right? What is another strategy that we can help an individual come back into their body? And I think, something that's so important, and all the yoga practitioners and Tai Chi practitioners, for example, have known this for thousands of years, is that the only way we can be embodied is through the breath, right? If our breathing is shallow and if we're afraid to breathe, we can't be embodied. And I think we so frequently see this in trauma, and I think we probably don't talk about it enough. Certainly, I didn't hear enough about it in my training, that, often we have freezing or tonic immobility of the breath, right, of the intercostal muscles. And so, especially when people get triggered, their breath becomes very shallow.
Yeah.
And what I've noticed, working with my clients is that they actually even have low oxygen saturation. So I often work with biofeedback with a pulse oximeter that they can track their level of oxygenation.
Interesting. Mm.
And it seems to be, especially in individuals with chronic traumatization, that they're at, sometimes 94, sometimes when they're triggered, they go down to 89%. And just to put that in perspective, right? If you're on a medical unit at a hospital and your oxygenation level was 94%, normal would be 98, 99%, you would get oxygen. And, 89%, I mean, that's very low. And so actually getting people to get the feedback through the pulse oximeter, in my experience, can be very helpful.
Yeah.
And then slowly bringing that breath online, which can be very triggering as well, right? That can trigger memories. So again, it has to be done at a pace that feels safe for the individual, but getting them to become aware of, their breath becoming shallow, their breath freezing or stopping.
Mm-hmm.
And then, there's different forms of breathing that we can help the individual to use to really embody slowly through the breath. And again, I want to share a case example here. I had a woman who we did, awareness exercises with, and she became aware that her breath would freeze several hundred times a day.
Wow.
And so she said to me, I've been going to this DBT group and I've learned box breathing and I really like it. So I breathe in and I hold my breath and then I breathe out. And I laughed. I said, of course you like it, because that's exactly what you do naturally, because your breath freezes. And she started to laugh as well, right? Because it made sense to her. And so what we worked on was this continuous breathing, right? Not stopping, but you want to breathe in like a wave, breathe out, breathe in. You don't want to stop the breathing, right? You want to make it like a wave. It comes and it goes. And so using that imagery actually did very well. So I think really thinking about the breath, how important that is, and how embodiment, I think, can only occur fully if we're really breathing appropriately, I think is really important.
Mm-hmm. Mm.
And then thinking about fragmentation of the self, and again, I mean, that could be, a whole day workshop, but, to really think about that and help the individual understand that each part of themselves came into being to help them to survive. So each part of the self played a critical role in survival. Because of course, individuals who are very fragmented often are really disgusted by certain parts of themselves.
Mm-hmm.
So for example, if a part of the individual was engaged in prostitution, for example, other parts of the self may be very disgusted by that, and that may be fueling some of that conflict. And so, really realizing that each part helped the individual to survive. And, a part that was engaged, for example, in child prostitution, I always say to the individual, that is an incredible part. The strengths of that part. Let's think about together what the strengths of that part are. And basically, one strength would be, if you can get through that, you can get through anything.
Mm-hmm.
Right? So really helping to become aware of the different parts of self, understanding their strengths, and starting to realize how some of these parts still have an altered sense of time, how they're still functioning as if it's the past. And so helping each part slowly and at a pace that they feel comfortable with, come to the present and utilize their strengths in the present. Because we need all parts of the self to survive, right? And to get through therapy. There's no surgery that we cut out certain parts. No, we need every piece of strength of the individual. And we just have to create empathy. We have to create an understanding, listening inside to really understand how each part of the self helped the individual to survive and how we can realize those strengths in the present.
Mm. Mm. So, Ruth, I want to loop back some of the sort of clinical applications you've been describing back into the question or your answer around the brain network. So, over periods of time when you're working with patients and you're sort of following various ebbs and flows in therapy, do you then see the reactivation of those brain networks?
Absolutely. And this is not just our group, other groups have shown this as well. But I think one of the networks we're really excited about is a network related to the sense of self. It's also called the default mode network.
Mm.
And when we look at that network in individuals before treatment.
Can you say a little bit about what it is first? Because some people might not be aware.
Absolutely. So the default mode network has three main brain regions. One in the back of the brain called the posterior cingulate cortex. And that's a part of the brain that is really involved with recalling past memories. And when the network is intact, it's very much connected to the front part of the brain, or what's called the dorsomedial prefrontal cortex. It's a part of the brain that helps us to know what we feel, but that also helps us to have a future, to think into the future. And then it's also connected to the parietal cortex that helps us to have an embodied sense of ourselves in space. And if we think about trauma, right, often we don't have that embodied sense of ourselves in space. We don't know what we feel, and we often don't have a future. And that's exactly what the brain network looks like in chronically traumatized individuals. Only the back part is connected. And it's a very profound image. We've lost the front part and we've lost the embodied self part. And so people are stuck in the past, essentially, with no future and no body.
Can I just ask, like, I'm just deviating a bit, but
yeah.
For example, for suicidal ideation, one of the things I often hear is, I would just want to end it now because there's no future. Yeah. And I'm just wondering if that part of the network that you're describing would be activated when that part of the individual is having that kind of ideation.
I think that's a great hypothesis. Yes, that makes a lot of sense, Tracy. Yeah, that lack of a future is horrible. Right?
Okay.
And so after treatment, what we're now seeing is that this network comes back online, which I think is what we see clinically. But I think it's so nice to see that the brain is malleable, it's plastic, and it can make some of those connections, and that the sense of self can be restored and embodied, right, through treatment. So I think, yeah, that really gives a lot of hope. I mean, we know it, but I think to see it has really helped to make the invisible injury more visible, right? I think something about mental health is that it's an invisible injury. It's probably the most painful injury, but it's invisible, right? And I think neuroimaging has really contributed to making that invisible injury more visible. And, our research participants always tell us how validating it is to know that, their pain and suffering is actually reflected by changes in the brain.
Yeah.
And I think that's going to go a long way in reducing stigma of mental illness as well, right? We have to keep making those incredibly painful injuries more visible and more understandable.
Yeah. What a good place to be in terms of, just in 2021 and sort of access to and evolution of neuroscience techniques, coming out and new things by various neuroscience departments being created. I think, as you say, it will definitely be more visible, the unvisible wounding, in the near future. And it already is.
Yeah. No, I think it's a very exciting time. we still know very little, but I think it's an incredibly exciting time. And I think each year we'll learn more and more.
Mm. Ruth, if it's okay with you, we're going to go on to some Q&A, and I'm going to have a look at some of the questions and just read a couple. So let's have a little look. Lots of questions. I'm just trying to pick just an interesting one. Okay, I think this is an interesting one. And it's something that we didn't cover. What therapies can reach these deeper parts of the brain, like the midbrain and the brainstem? Maybe you just want to rattle off a handful.
And of course, that's such an important question, right? And I think so often our patients will come in and say, yes, I know the assault wasn't my fault, but I can't stop feeling it. And I would hypothesize that's exactly when we haven't dealt with those deep parts of the brain. And I think therapies that deal with those lower parts of the brain, I would hypothesize that somatic experiencing, of course, is very much a therapy that deals with that. Sensory motor psychotherapy, the occupational therapy, sensory approaches. And I think that's something we really need to bring into the field of trauma. All this is altered sensory processing. So how can we change sensations to really change upper levels of the brain? Of course, Steve Porges talks about that, for example, with the Safe and Sound protocol. That would be one aspect. Occupational therapists are brilliant at it. That's what they work with. And so we need to think more and more about that. And then neurofeedback, our group has actually shown this, that neurofeedback treatment can change connections with the reptilian brain, specifically the periaqueductal gray. So I think it's all about elegantly combining these bottom-up and top-down approaches, really thinking about different forms of sensory input to change the brain from a bottom-up kind of method.
And things like EMDR, sensory motor psychotherapy, do you advocate those or not really? Or
Absolutely. I'm all about an integrative approach. I've been trained in many different modalities, and I think it's all about a personalized integrative approach. All the patients I see, or 98% of the patients I see, have not done well with different approaches where they've just had one approach. And so I think we need to work integratively and really embrace different therapeutic modalities and realize, different individuals will need different combinations of approaches.
And I'll just rattle off some others. And again, always just good to hear your thoughts. So brain spotting, internal family systems. We were talking Tuesday about Frank Corrigan's new work.
Yeah, deep brain reorienting. EMDR, I'm a great fan of EMDR as well. Dialectical behavior therapy.
Yeah, IFS.
Absolutely, absolutely.
Dick Schwartz's, yeah.
I use Dick Schwartz's treatment all the time as well. And not just in the highly dissociative individuals, of course, but as Dick has taught us, all of us have different parts of self, right? Yeah. And I think that's also something that's really missing in our psychotherapeutic training, especially in mine, that, just because one part of us comes to therapy, we can't just deal with that part. We have to see the individual as a whole person, and that different parts may be responsible for different forms of suffering.
Yeah.
And just that in dissociative clients, severely dissociative clients, those parts of self, of course, are more separate. I think the IFS approach is really important.
Thanks. Just a big shout out to a couple of people, Sally, and I missed the other one's name. We said brain spotting. They just popped up, so thank you for reminding me. We'll take another question. So Jasmine says, would you say that the amygdala evokes the subconscious or unconscious in relation to trauma responses of flight, fight, and freeze, flop? Or is this another part of the brain?
No, that's another part of the brain. That's the periaqueductal gray. and it's in the midbrain, so it's lower than the amygdala. And the periaqueductal gray actually is subdivided into different little structures, and it has a little structure dedicated to active defensive responses, and it has a little structure developed for freezing or tonic immobility, and it has a little structure dedicated for emotional shutdown and collapse. And, you know, the sensory input comes right into the periaqueductal gray from both the body and from the outside. And so very quickly it can determine what is the greatest chance of survival and what defense mechanism is most appropriate for the individual. So yeah, it's important to know that those different defensive responses originate in the periaqueductal gray and in the midbrain. So it's lower in the reptilian brain, very deep.
And the first time I heard about the PAG was years ago, but that was thanks to Lisa Schwartz, who does CRM, which is comprehensive resource model. So, you know, just another therapy for those people who are interested. Sort of CRM really does some great stuff with the PAG.
Raw emotion, right? It's really focused on the raw emotion. And what's interesting to know, I think Lisa Schwartz also uses a lot of different breathing techniques, and the periaqueductal gray is also critical for breathing. It sort of all comes together in that reptilian brain.
Yeah. And I'm going to take another question. So Deb says, once the client is present and grounded to the five senses, do you think mindfulness would help? And I'm going to add, can you also talk about the contraindications of mindfulness for trauma survivors, please?
Yeah, I think that's a great question and such an important question, because as we know that when traumatized individuals sign up for these standard mindfulness trainings, often they get very triggered and get flooded by their emotions. And so I think whenever we do mindfulness, it has to be trauma informed. Just like we talked about the body scans, right? If you start a body scan like we would do it in somebody who's non-traumatized, you know, doing the whole thing, you know, thinking, oh, somebody can do this easily, we can really trigger an individual. So whenever we do mindfulness, it has to be trauma informed. And we talked about how to do the body scan, but how about just meditating? And I always give this example. I have a woman, you know, who I work with who was very chronically traumatized, severe childhood trauma, and she went to a church group to do meditation. And they got her to meditate for 45 minutes. And she was completely flooded with anger, sadness, panic, completely flooded. And she'd been in therapy for a long time, so she'd gained a lot of skills. So it only took me a few weeks to kind of settle her back down. But I think it's such a good example. And we see this all the time in people who come from these standard mindfulness trainings who've been traumatized, that they get very overwhelmed. And so I think, again, we need a personalized approach to meditation. And we really need to figure out what is the maximum time, again, in collaboration with the individual. You know, is it 1 minute? Is it 30 seconds? Is it 2 minutes? Is it 3 minutes? Is it 5 minutes? But everything has to be scaled back in trauma, right? We need to titrate it. Meditation, just like body scans, it needs to be titrated, and it needs to be done in collaboration with the individual and with increasing emotional awareness and really staying within that window of tolerance.
Yeah. So take either one or two more questions. I think this is an interesting question, and I think we've spoken to it already, but I think it would be good to hear what you say, Ruth. Tracy says, what if people can't get treatment to restore a sense of self? What can we do as friends, family, or youth workers to bring back on the connections? maybe you want to talk about that, but sort of also talk about, you know, parts of the self that might believe that they don't have a self, or about sort of hope and efficacy for the future.
Mm-hmm. Yeah, I think, you know, when we think about treatment, first of all, I think giving the individual hope, you know, saying they've survived the unbearable, the intolerable. So there are tremendous strengths, even though, you know, parts of themselves may feel that they're dirty, disgusting, and have no strengths. Really sticking with that, you know, no, that's not true. You've done a tremendous job, you know, really in the midst of the unbearable and the intolerable. And so keeping that hope going for them, and my patients often say that to me, and I often say to them, you know, when you lose the hope, I will hold that hope for you. And, you know, until you can see it again and feel it again. And then I think if no formal treatment is available, really getting the individual to think about, you know, what their body is seeking, you know, what sensations their body is seeking. So for example, they might want to engage in karate, right, which brings online active defensive responses. It's not trauma treatment per se, but can be incredibly helpful. Or Tai Chi or yoga, again, if they're ready. It needs to be done in a trauma-informed way, but also really empowering them to say no and to keep getting more in touch with themselves and figuring out, does this feel right for me, or doesn't this feel right for me? Or, you know, developing, if somebody has tremendous writing skills, a lot of my patients write extremely well, you know, writing about their experience, writing about their dreams once they're able to dream and have imagination. Often that's severely curtailed, of course, in the aftermath of trauma, but writing about their experiences, drawing, artwork. A lot of traumatized individuals, again, are very artistic. And so, you know, getting into a group where they can express some of those creativity, I think can be incredibly helpful. And really, you know, taking it back again to a much more basic level, you know, for example, the room they're living in, bringing it back to grounding and what sensory input feels the most safe for them. You know, for example, what color does their wall need to be for them to feel safer? You know, what texture does their blanket need to be in order for them to feel safe? You know, how does their bedroom need to be organized for them to feel the safest? And so really taking some very basic steps, empowering the individual to help them to figure out, you know, what they need to feel an increased level of safety.
Yeah, so true. Ruth, I'm going to squeeze in one more question because we started at 1 minute past 6.
You go, Tracy.
Zadi says, do we know what stops the brain from adapting back when the unbearable has passed?
Great question.
Yeah, I could not ask that, sorry.
So I think one thing we know as therapists is that the restoration of the self is incredibly frightening because it's the unknown, right? And so I think we have to honor that, and we have to bring that up in treatment. And we have to discuss with people what's most frightening to think about the restoration of the self. And again, I think reassuring the client that we're going to go at a pace that feels safe and comfortable, that we're not going to rush this. Because if it's too terrifying, then therapy can get stuck. And so we're going to work together at a pace that feels comfortable and safe, and really help the individual parts that may be most terrified, or they may feel the individual is not deserving of getting better, to really work with them to reach that goal, which is the restoration of an embodied self.
Thank you, Ruth. It's been amazing. Thank you so much for your time today.
Thank you, Tracy, and thanks for a great conversation.
Yeah, and we're going to see you next month with our Trauma and Attachment Conference. So yeah, you'll be on for that. And hopefully everyone, if you enjoyed this, we're going to be doing some great collaborative things with Ruth moving forward. So stay tuned and goodbye from me. Thank you so much.
Thanks, Tracy. Thanks,
Bye.
everyone.
Bye. Bye.
Bye.